All right, your malignancy chapter. The first part of your notes, obviously, is just kind of an overview about assessing the child with cancer. That figure comes, and of course what I have on the slide comes straight from your book. It just depends on what type of cancer we have, what kind of symptoms we're going to see. And again, those are just general things that we can ask about with our history and the physical exam. Some of the things we might see, we'll go more in depth as we go along with the different malignancies that we talk about. And then, of course, on the bottom of page 1, some of the diagnostics, general diagnostics, we use X-ray, ultrasound, MRI, blood analysis, biopsy, staging, to help with staging, aspirations, those kind of things. So we look at all of those to find out what's going on, and then, of course, to truly diagnose and then plan our treatment. So as an overview of our cancer treatment measures that we're going to use with kids, it's going to be one of two things. We're going to either try and do surgery to remove or resect whatever the tumor is, if we can, radiation or chemo. And of course, one of the other options, there's a couple other options: stem cell transplant, immunotherapy, general health measures. But the three that we really focus on when we go through the different ones is really they're either going to be one of three things or in a combination of those three things, and that's the surgery, the radiation, and the chemo types of things. In your next several pages, the first part, it talks about what is radiation, what happens, what are the side effects, long-term effects. I'm not going to go through that. That is not new information. You can read through that yourself. I do want you to review that box that I referred to on page 2 of your notes that says C box 53.5, caring for the child receiving radiation therapy, because that's, again, going to kind of talk about what do we need to teach families, and how do we care for someone who's getting radiation, what kind of things can we do to help with the side effects. Same thing when you get into the chemotherapy that starts on page 3. All I really want you to understand about chemotherapy, I don't want you to necessarily understand or know the different types of chemotherapeutic agents. I want you to really understand what is the purpose of chemotherapy, and what kind of things do we need to do when we're administering chemotherapy to keep ourselves as the nurse safe. And then again, dealing with the side effects of chemotherapy, and what kind of things can we do as a nurse or to help lessen those side effects or manage those side effects, and how do we teach families to manage those. That's, again, what I want you to be able to get out of the chemotherapy and the radiation. I as well refer you on page 4 of your notes to 2 different boxes. Right in the middle of your page under that mucositis, box 53.7 on page 1573, tips for relieving the discomfort of mucositis. I would look at those, and also the box about susceptibility to infection. It's box 53.8 on page 1574, preventing infection in the child with neutropenia, because those are common big issues that we need to know and be able to understand, and to teach our families and how to minimize and care for those different side effects that we're going to see. So definitely look at those things for the test, and go from that. And again, one of our other options is stem cell transplant. That's kind of one of your last resort if we're not, well, of course, it depends on what type of cancer we're talking about. But if they're not responding to other treatment, this is something else that they can use as well. Let's talk about leukemias. There's 2 different types of leukemias, but I really want you to focus, there's more than that, but we're going to really focus on one type. But leukemias in general, there's a distorted and uncontrolled proliferation of the white blood cells. So it's affecting those white blood cells. It's the most frequently occurring type of cancer that we see in kids, is the leukemias. So it's affecting, instead of having a solid tumor, it's affecting those white blood cells, which then, of course, are circulating in our body. So the one we're going to really focus on is the acute lymphocystic leukemia, or the lymphoblastic leukemia, or ALL is sometimes how it's referred to. What I like about this slide is it kind of shows you what normal blood looks like under a slide, and then when you have leukemia, what the difference looks like. So you can see the difference in your white blood cells and how you have all different stages and that rapid proliferation, or the uncontrolled proliferation of the white blood cells. So with ALL, it involves the lymphoblasts or immature lymphocytes, which are part of your white blood cells. And because of that rapid proliferation, you have the immature lymphocytes. And then the production of the red blood cells and the platelets falls because of that. And then, of course, you have the invasion to your other body organs because of the rapidly increasing white blood cell elements. So again, you have those immature white blood cells that are crowding out other organs. Your peak incidence that you're going to see this in is your 2 to 6 year olds, slightly higher in boys than girls, and more often affects Hispanic and white children. It can affect all races, but it does tend to affect those groups a little bit more. The actual cause of the leukemia is unknown. It is there is a link to, or thinking that there's a link to the exposure to chemicals and radiation, maybe some genetic factors that can certainly make someone a little more prone, but the actual cause itself is unknown as to why they get leukemia. You can see your general signs and symptoms that you're going to see with leukemia, and when we're going to do an assessment, the things we're going to see, of course, associated with the decrease in the red blood cell production. So we have anemia, and because of the anemia, we're going to see the pallor, the low-grade fever, lethargy. Other things we're going to see the low thrombocyte or platelet count, which can lead to the petechiae, easy bruising on arms and legs, bleeding from oral mucous membranes. We're going to see the spleen and liver enlarge because of that infiltration of those rapid proliferating white blood cells or the lymphoblasts. We're going to see crowding. So that's why your spleen and your liver is going to be enlarged. So then they'll complain about abdominal pain, the vomiting, the anorexia. They'll often complain of bone and joint pain. Again, the abnormal lymphocytes invading the bone periosteum. And then when we have CNS invasion, we can see headaches and unsteady gait. And of course, their physical appearance overall, they usually have painless generalized swelling of their lymph nodes, especially the submaxillary or cervical lymph nodes is what we're going to see. To diagnose leukemia, of course, we're going to base it on their history, getting a detailed history, as always, looking at their physical manifestations. What kind of symptoms are they having? When we start to look at the different blood work that we can do, we're going to see elevated leukocyte counts. We're going to see platelet and hematocrit is low. Our red blood cells are present, but there's few of them in number because, again, that decreased production of the red blood cells. We're going to do a lumbar puncture. That's going to show us evidence of the blast cells and the CSF fluid. Of course, we're going to do x-rays of the long bones because we're looking for any invasion of those abnormal cells. And the gold standard for diagnosis of ALL is the bone marrow aspiration because that's going to identify the type of white blood cell involved, and then, of course, tell us what type of leukemia it is. So when we talk about the therapeutic management for ALL, what I really want you to know and understand, they're going to get chemo is what's going to happen. They're going to get chemo. There's going to be 4 phases of it. And what I want you to really understand is not the different types of chemotherapy that they're going to get, but really how we're going to treat it. And we're going to start that, again, it's all use of chemotherapy in every one of these phases. They're going to start with induction, which we're trying to get them into remission in the absence of those leukemia cells. So they're going to get chemo, systemic chemo. And of course, with chemo, when you go back and review about chemotherapy, we need to worry about with chemotherapy, when we start chemo, they need to be well hydrated, or if they're not well hydrated, we need to be looking at their urine output because they often have high levels of uric acid that have to be excreted with the chemotherapy. And a lot of times, if they're not well hydrated, then the uric acid can build up in high levels, which can cause plugging of the kidney glomeruli, which then can lead to loss of kidney function. So we have problems with filtration if we don't keep them well hydrated to help excrete this uric acid that builds up from the chemo. So again, keeping them well hydrated, administering drugs, and the drug that they refer to a lot of times that will help reduce the formation of the uric acid is the alpurinol to help maintain that safe uric acid secretion. After the induction phase, then we're going to move into what's called consolidation. Again, it's more chemo. However, the route that we give the chemo is going to be different. It's going to be intrathecal administration. And again, it's just trying to prevent with doing intrathecal, we're trying to prevent it from invading and growing in the CNS system and affecting it that way. Then we move into the intensification phase, which again, it's more chemo, and our whole point is to just eradicate any kind of residual leukemic cells that may be floating around elsewhere in the body, because we don't want that to replicate and then of course cause further problems. And then the last phase is the maintenance phase, and that's about preserving the remission. And really, when all four of these phases, again, it's different types of chemo, but know that they're going to get chemo. That's what I want you to get out of it. If we, in any one of these phases, if they relapse at any point in time, then we're going to have to go back and start back at the beginning with induction and go through each phase. All of these phases can take several years to get through. It may be quite some time that they are dealing with this. It is not like it's a matter of a few weeks or months. This is long-term treatment when you talk about getting through all four phases. And when you look at the prognosis too, obviously the more times if they relapse, then the likelihood of survival decreases each time. But between the children between 2 and 10 years of age have the better prognosis as well. And children who are free of the disease after 4 years are considered cured, and then the maintenance therapy can stop. So you can see the different complications. Obviously, there's CNS involvement. If there's CNS involvement, those complications, renal involvement, testicular invasion, and again, looking at our nursing care when we're talking about giving chemotherapy, being supportive, and of course just the diagnosis in general of ALL and leukemia, you need to be very supportive of the family. Let them, talk about their feelings, be able to make sure you prepare them for tests and procedures, and what their treatment plan is going to look like are all important. We also need to manage their pain. They often need pain management and need narcotics. They can also do some non-pharmacologic measures. And then the big one is we need to prevent complications of the myelosuppression. So decrease production of the cells. Those things we're going to look at: infection, trying to reduce infection rates. So things we're going to do: private room, limit visitors, strict hand washing, administer antibiotics as needed, encourage that adequate protein intake, because that's going to help fight off infection. And then one of the other complications we need to worry about with myelosuppression is bleeding. So with bleeding, things we want to look at, of course, decreasing the incidence of infection, because infection just increases the tendency to bleed, and bleeding from different sites, which then those sites can be more prone to infection. So infection is huge even with bleeding. The other things obviously to prevent bleeding is limiting puncture sites, getting them a pick and drawing from a pick line or central line that they have, versus having to stick them peripherally multiple times. Ideally, if we can get that pick line or central line in, that's going to reduce those limit those puncture sites. Of course, with that, we need to, trying to prevent infection, do good central line care and dressing care for the central line or the pick. Avoid rectal temperatures, which we pretty much don't do anymore at all anyway, but we need to limit those, of course, because they're more prone to ulceration and mucositis anywhere in their GI tract. We need to monitor for decreased white blood cell count, because that's related to the hemorrhage and CNS involvement. And then, of course, we need to monitor for bleeds and looking for those signs and symptoms like the petechiae, the ecchymosis, the hematemesis, the bleeding gums, the tarry stools. So it can all be signs of bleeds elsewhere. And then the last complication from the myelosuppression that we want to try and watch or take care of is the anemia. Because of the diagnosis from the bone marrow suppression, blood transfusions are often needed. So they need blood transfusions as ordered. And of course, look back at those slides about blood transfusions in the proper way and what things do we need to do when we're giving a blood transfusion and monitoring for reactions. They often need, because of the anemia, frequent rest periods. They may need some supplemental O2. IV fluid replacements are all important. So being aware of those things are really important when you have someone with leukemia. And then, of course, teaching. I've already kind of touched on about teaching the family about diagnosis, treatment plans, staying away from when they're home and not in the hospital, staying away from people who are sick and limiting the amount of visitors. Those kind of things are all really important in the long-term treatment. When you talk about the acute, I know on page 10 you have the acute myeloid leukemia, or AML. I don't really want you to focus on that one. I really want you to focus on the ALL for study purposes. So look that part over, and then don't worry about the acute myeloid leukemia. Let's talk about your lymphomas. With lymphomas, we can have Hodgkin's or non-Hodgkin's. That's typically how they're categorized. They do occur more frequently in males versus females, and they're malignancies of the lymph or the reticuloendothelial system. So let's talk about Hodgkin's first. In Hodgkin's lymphoma, we have the lymphocytes are proliferating in the lymph glands, and you'll typically see the Reed-Steinberg cells develop. And then the actual etiology of Hodgkin's is not really known. Again, they think there may be an environmental or genetic link that predisposes them. And then our incidence is typically we see this more so in the adolescent and young adulthood ages. It is a neoplastic disease that originates from the lymph system. As you can see in this slide, there's all different places that, with the lymph system and different lymph nodes that we can often see this present itself. But they can often metastasize because it is using the lymph system is how it spreads. And metastasize, you can see metastasis to the spleen, liver, bone marrow, lungs, other tissues as well. When we do an assessment of somebody with Hodgkin's disease, we're going to look for symptoms. They usually begin with an enlargement of only one painless and enlarged and will be rubbery feeling cervical lymph node. It can involve other lymph nodes, or the other lymph nodes will become involved, usually along with the liver, spleen, bone marrow, and eventually the CNS, again because of the metastasis, and it's using that lymph system to spread. Accompanying symptoms that we're going to see, anorexia, malaise, night sweats, weight loss, fever may be present. Their SED rate will be elevated if you do some blood work. Their anemia, there'll be anemia present as well because of the result of the reduced red blood cells survival. And our diagnosis is confirmed by a biopsy of that lymph node that is enlarged. And then, of course, we're going to do further studies to actually stage and classify the disease, which then will tell us what kind of treatment plan we need to do. So when we look at the treatment plan, treatment, again, depends on that clinical stage at the time of diagnosis. But usually it's a combination of chemotherapy, different types. Again, I don't really want you to know the different types of chemotherapy. Just know that they're going to get chemotherapy in all stages except for stage 1. Prognosis-wise, a 90% 5-year survival rate for children with stage 1 or stage 2 disease. More advanced stage disease, then it's a 60 to 90% chance for survival. If we have relapse that occurs, then they're going to get additional chemo, radiation, or bone marrow transplant will be scheduled. And of course, our nursing care, preparing of diagnostic therapeutic procedures, explaining side effects of chemotherapy and radiation, and of course supporting and explaining everything to the child. And all right, neoplasms of the brain. It's brain tumors. Brain tumors are the second most common form of cancer, and they're the most common solid tumor form that we see in children. They tend to occur between 1 and 10 years of age, with the peak age at about 5 years old. They tend to occur more midline in the brainstem or the cerebellum, which makes it harder to remove because without damage because it is because of its location. The different types of brain tumors, I don't want you to necessarily know those for study purposes. I just want you to understand, there are different places we can see it. And really, when we have a child who has a brain tumor, what do you think you're going to see? You're going to see symptoms of increased ICP. You should already know that from the last chapter, the last not the last chapter, but the last test material that we just talked about. So you're going to see symptoms of increased ICP, the headache, the vision changes, vomiting. If it's an infant, enlarged head circumference. You might see the papilledema, lethargy, projectile vomiting, coma or late signs. And And then, of course, generalized symptoms that are different from the increased ICP, but because of the increased ICP, generalized symptoms you may see, the nystagmus or the visual field defects, as the tumor continues to grow, the ataxia, personality changes, seizures may occur. Because what's happening why do you get the increased ICP? Well, you get that because of when you have a tumor growing in there, it's not supposed to be there, it's taking up more space, which then is going to create pressure in your head. So then as that tumor gets larger, then you're going to see those increased ICP symptoms. When we do diagnosis, we're going to do a thorough neurological exam. That's going to kind of help tell us more so where maybe the tumor is located and how it's affecting the child. Of course, we're going to do skull films, bone scans, ultrasounds, x-rays, MRIs to get the full picture. We're going to do an LP cautiously because we especially worry about the brainstem herniating into the spinal cord, which then if it herniates, it affects our respiratory and cardiac function. We talk about therapeutic measures. I'll talk about those on the next. Okay, I lied. There wasn't a next slide. I'll just do it on the same slide. But therapeutic measures for a brain tumor. Really, what we're going to try and do, we're going to try and they're going to do a combination: surgery, radiation, chemo. Depending on the size and extent and location of the tumor is kind of how they're going to predict the course. But they may do some radiation therapy or chemo initially to kind of help shrink that tumor. Ideally, surgically, what they're going to go do, if they can get it completely out, they're going to completely remove it. If not, they're going to resect it as much as possible. Well, if we go and operate on the brain, then what do you think our post-operative care is going to look like? We need to worry about increased ICP. So we're going to do all those measures, even preoperatively. We want to reduce anything that could create increased pressure. So preoperatively, doing the stool softeners, doing Decadron to help with any cranial edema, doing the anticonvulsants, especially if a kid is having seizures, doing those to try and limit that. Shaving the child's head, which can be traumatic depending on the age of your kid. But, making sure that they understand it will grow back. When we talk about post-operative care, again, it's all focused on all the different types of measures that we talk about reducing increased ICP. So I'm not going to review that. That's not new information. So you can look that over. But again, actual therapeutic treatment is mostly we're going to try and resect or remove completely the tumor, and then, of course, the combination of chemo and radiation as well. All right, another one you can skip on page 20, the Rhabdomyosarcoma. Don't worry about studying that one. We're going to jump right into the Wilms tumor or the Nephroblastoma. Starts on about the middle of page 21 of your notes. So Wilms tumor is a malignant tumor that occurs in the kidney. There's no increased incidence based on sex or race. It usually is discovered early in life, sometimes the 6 months to 5 years, with the peak age being 3 to 4 years old. Their clinical manifestations, they often have abdominal swelling or a mass. It's firm and non-tender. They can have hematuria due to some hemorrhage within the tumor itself. And then oftentimes they will have hypertension because of the excessive renin production. But think about the age that we're talking about that we see the peak incidence. We see the peak incidence as 3 to 4 years old, but even at 6 months, we don't routinely take blood pressures in these kids. If they've had no health problems and they're just going in for regular checkups at the doctor's office, we're not doing blood pressures in these kids. So it's not a reliable method to diagnose or discover it, but they do, once obviously we start checking their blood pressure, they do often have hypertension. They will also usually have a low-grade fever as well when we end up talking about what their signs and symptoms that. All right, when we talk about diagnostics, we're going to do, for Wilms tumor, we're going to do a CT scan and ultrasound because we're looking for revealing that primary tumor, and of course, how much has it spread, if it has spread, and the points of metastasis. The other big one we need to do is kidney function studies. So if it's in our kidney, obviously it's going to affect our kidney function and our urine output and filtration. So we're going to really look at those things. And when we talk about therapeutic management in a moment, we're going to have to remove the kidney. So, of course, preserving the other kidney and that function is really important in the care of the child with Wilms tumor. The other big part when we were talking about diagnosis is we want to avoid palpating the child's abdomen and do it as little as possible for diagnosis, because they've found that the more you're handling or palpating that abdominal mass that is felt, it can aid in the metastasis. So the other big part when we get to nursing considerations is making sure we hang a sign above the head of the bed saying do not palpate abdomen. Therapeutic management wise, again, like I said, it's going to be surgical removal. So they're going to have a nephrectomy, remove that kidney that is involved. Usually it is only one kidney. Rare instances it could be both, but most times it just involves one kidney. So we're going to remove that kidney, and then it's going to be followed by radiation therapy and chemo. And chemo could last as long as 15 months. Again, our nursing considerations, placing that sign above the head of the bed saying do not palpate the abdomen, really important prior to surgery. They're going to do this surgery pretty quickly. They're not going to wait long to, as long as they can get the kid in and everything is stable, they're going to get it, remove that tumor in that kidney as soon as they can. So preoperatively prepping them for surgery, teaching them about chemo and radiation and their treatment plans, and those side effects are really important. When we talk about post-operative care, nursing-wise, we need to have a good GI, monitor their GI assessment and activity, because there's an abdominal mass and we're in the abdominal cavity. To get access to remove that kidney, they're really at risk for intestinal obstruction. So really monitoring their GI activity is important. Of course, looking at their vital signs. Definitely want to look at their urine output, because now they only have one functioning kidney, and we want that one kidney to function very well. And of course, looking for signs of infection. We need to incorporate play therapy as well and educate on prognosis and treatment plans. Allow parents to talk about their feelings so that they feel supported and being able to cope. That's a way for them to cope with what's going on. One of the other things too, talking about, I kind of hint on it, was with our teaching and support, or teaching the family, is we need to make sure they understand, because they only have one kidney left, we need to really protect that kidney. So a lot of precautions that they need to make sure they understand is especially avoiding contact sports or anything that could cause an injury. We want to try and prevent, because we really want, we need that one kidney for function. So protecting that to the best abilities that we can. The other piece is, of course, making sure that they know signs and symptoms of any kind of GI issues. Like think about like UTIs, things like that. Because we want them to be able to recognize those signs and symptoms early so that they can get proper treatment started as soon as possible, so we can preserve that function of that one good kidney. And of course, again, you can read through the family support and teaching that is there. I've kind of already hit on a lot of those things, but kind of read through that. As for the last part on page, so that's it for Wilms tumor. And then the last part, retinoblastoma, that's on page 23 and 24. Don't worry about studying that for your final. I just want you to focus on the ones that I've already covered, so you can not worry about retinoblastoma.